Thank you very much. I really appreciate it, and especially with the beautiful weather outside, I'm impressed you're all here. I didn't pick up the title. I think it was meant to be a bit provocative, but you'll hear me say a lot of things against slings that will echo in some ways what Chris Chappell just said. So, Chris, thank you very much for introducing that already. I don't have anything to disclose. I don't work for any company. I never place tape or will. I recused myself from the Thomas trial that Chris mentioned, even though I was a member of the UITN, but I didn't want to do these procedures in women, and I've never published any paper related to that Thomas trial. So where do I stand here, and why am I against so much this midurethral sling? And this is not new. I've been at that since 2000, so a long time. When I trained with Dr. Raz at UCLA back about 30-some years ago, I learned several concepts from him which stick with me all my career, and I'm going to go through that with you. First, stress incontinence to me is a vaginal disease, so it's basically the movement of the of the urethra associated with the vaginal wall. When it detaches laterally, that's really what leads to stress incontinence. And if that's the case, and she leaks when she coughs or sneezes, and it's from lateral detachment, why are we torturing this poor urethra with a midurethral sling? I never quite understood that. Secondly, if you look at the theory which I have, the theory says that there are ligaments between the urethra and the back of the pubic symphysis, but in fact, those ligaments do exist, but they never run toward the urethra which sits in the middle. So there's really a big problem with this theory. What we see, though, when you do a birch, for example, you see those ligaments sitting here, the urethra in the center, and you see beautiful lateral tears, which is really why the vaginal wall moves down, and that's why this woman is leaking when she coughs or sneezes. So why are we addressing the urethra when the problem is not there? And that's what basically others have written. That's a fundamental issue with that theory. And I'm not going to deliberate too much on that, because obviously if that was truly the issue and that was really damaged, then all our birches would fail, because what you do with a birch or vaginal suspension is support the vaginal wall. And if the urethra was damaged, then they would all leak afterwards. Now, the second important concept was obstruction after Marshall Marketic Krantz. This was kind of the big operation back then. And the lesson there was get away from the urethra. Don't get too close. Every time you start to dissect around the urethra, you're going to denervate, kink, and devascularize the urethra. And isn't that what we do every day when we put midurethral slings? And lastly, at least when I trained, the problem was that sling was the last resort procedure. It was impossible scientifically to tension it right. And as Chris alluded to, the tension-free concept is obviously not right. So there's a risk of lifetime retention, and there's a risk of bladder wall changes with obstruction that is a long-term problem. Chris mentioned this, and just to give you some numbers, those are the 2 years data from the sister trial. And clearly you can see, if you look at the numbers, at 2 years after placing the birch, your flow doesn't change, your pressure doesn't change, but look at the changes for the sling arm. The flow goes down and the pressure goes up. No matter how you call that, to me this is obstruction. It may not be severe obstruction, they may not all be in retention, but you get dry from a sling because there's an element of obstruction. So what's going on with this midurethral tape? Well, yes, it is tension-free. You all do this operation very well. I've read countless operative notes describing very well how it's placed, but that's in the operating room. The next day she stands up, she coughs, she pushes for bowel movement. It's no longer tension-free. And then what happens? They heal. When they heal, there's fibrosis forming, and it pulls up and retracts. We've learned that with larger vaginal mesh. It's become very apparent that you scar the vagina and get trouble there. But same here with the tape. So even in expert hands, you see complications. And so as for any other sling, it's either end up being too loose or too tight, occasionally right. Now, the second problem as well is that as soon as you fix the midurethra, you allow the rest of the vaginal wall to rotate around. And when you do that, you end up with problem of obstruction, ballooning of the urethra, urgency with changes in position. So your patients are delighted. Short term, they're all dry. They're happy with you for those who can void. But then in the long term, you get trouble, and I'll come back to that in a second. So what I pretty much wrote about at the time was expected to arrive. If it's too tight, they have obstructive and nerve symptom, and if it's too loose, it recurs, which is the minority of time. And many of our patients have pain with intercourse, and then some of them get exposure vaginally or the urethra, which creates a whole slew of new problems to deal with. I've never had to remove rectus sling, but I've removed countless number of midurethral slings. There's not a week I don't remove 3 or 5 in my institution. And how to remove it and how much to remove is a challenge. Patients tend to be sent to me by lawyers. The lawyers want as much of it as possible. Some people argue you should incise them, excise them. The techniques vary. And once you've removed that tape, for those of you in the room who have done that, you know how little of the urethra is left because it's never on the surface, it's deeply embedded in the wall, and you're left with a very difficult urethra to deal with afterwards. Not always easy to do. We see urethrovaginal fistulas. People have no idea how deeply they are. If you do this operation, you have access to ultrasound preoperatively. Look at the ultrasound to see how close it is to the surface of the urethra. And if you have a patient like this one with a large amount of urethral erosion, you'll have a completely damaged urethra by the time you're done. If you do this open, you can try to debulk by using the holmium laser, a technique I owe to Nikesh, who informed me of that several years ago. We met at the ICS together. Now, there's another aspect of that is what's the long-term data on removal? There's really none of that. So I'm not sure what you guys tell your patients. We'll go back to the FDA 2013 where you have to explain to the patient all that can happen. There's no data on what happens really if the operation fails or if you have to remove it. So what do people tell their patients? I have no idea. Speaking of problems as well, what happened when they leak again? That's not mine, okay. So what happens when they have had one tape, they leak? Some people say, all I know to do is put another tape, so they put another tape. Some patient will run away from them, but some will accept that. And then you remove it because they still leak or they have a problem avoiding at that point. And you're left with a urethra that has had 2 tapes now placed, sometimes on top of each other or next to each other. And it's very hard to fix those people's incontinence. You don't have a urethral wall to work with for injectable. If you put a fascial sling, it's very easy to put in the retention, and sphincter is contraindicated when you have a weak urethral wall. It's like after diverticulum. You should not put those because they will erode. Some of these people have tremendously complex management with mixed incontinence. They have chronic obstruction that leads to bladder wall damage. Some of them have permanent pain. That was one of the very strong points of the FDA 2011, where the point was made that even if you remove this device, the pain may continue. They may not be able to have sexual activity. And frankly, again, dealing with specialized tertiary care center, I see those patients whose life has been destroyed completely, and I don't have any treatment to offer them. I've removed as much tip as I can, and they still hurt. What do you do next? Now, in terms of obstruction, we have a big problem also because those patients do age. And you do this in a patient who's 55, now she's 65, and she has bladder overactivity, and 10 years ago she had a sling. So is this age or is it obstruction? And it's hard to treat people that are obstructed because your anticholinergic drugs won't work that well, and many of them will go into retention. And we don't have excellent diagnosis for obstruction, as all of you know. We have some, but they're not great. So this is a pretty, sad perspective on sling, but that's again coming from a tertiary care. But I can tell you that's how we speak at meetings nowadays. We don't talk about how well our patients do. We talk about all the issues that we have of pain management, incontinence, urgency, etc. And sadly enough, too, we finally had to come up with a complication classification. It's the first in our field. What a sad thought that we have to come up with a classification complication that all the societies agree with. And that's how we have to report them in journals nowadays. So obviously when I talk, sometimes people say, but I never see this. And this is, Dr. Zimmer, what are you talking about? Well, my question is, do you see all your patients back? Do you follow them long term? Do you really know what happened to them? Well, they come back to see you if they have a complication. And have you heard, do you call each other and say you have a complication? Every time I do that, the surgeon I call say, oh, it's the very first time I hear that I have a complication. All my patients have done so well. So I think we really are a little bit into a nebulous world here in terms of figuring out our own outcomes. And I want to alert you, we do see late presentation. Those are people that will never go back to see their original physician. This lady is 6 years after TOT. She has a beautiful kink. She has a residual. She also had a sacrocolpopexy. This one is 8 years out. Same thing here, mid-urethral narrowing and residuals. Those patients don't go back and see you, so you'll never know they have a problem, but I will in my tertiary care practice. And as I just alluded to, those are tough patients to deal with. Some can still be obstructed even after tape removal. Some need vaginal reconstruction as well because they've had tape and mesh. Some have had 2 tapes, so you have to remove the 2 tapes. I can go on and on. The other sad part of all this is our scientific societies. I'm sorry to say we're not very glamorous in that pictures, in the US at least. They did absolutely nothing. All the move came from patients and networking, so we're very grateful for the internet for that. They basically, through networks, people not sleeping at night, looking at what happened to others, figured out that, you know, there are some people that are expert at removing these things and came to see us. Then the lawyers got involved, and now there's not a place you go in the US where you don't see an ad every 10 minutes about mesh and tape removal. Finally, the FDA stepped in, as you heard, in 2008 and 2011, and in 2013 they even came up with a very, very clear statement, which is directed to inform patients that want to have stress incontinence surgery, and those are about 14 questions that you have to ask, and one of them is very difficult, and it says, have you had specialized training in the treatment of incontinence, and which type of product, and how did you train? As you probably know, in the US, the way to train is by watching someone doing it, attend a cadaver course, or observe someone, but there's no hands-on, you know, peer-to-peer ways to learn how to do this operation, which could be part of the problem in many ways. So the question goes on to how many you've done, and some people say that normally when you consent patient now, you should tell them how many you've done. So how you tell the first patient that she's the first one or the second one, not very easy to say. And they want to know if you have a complication, are you able to deal with that, or will you refer me out? I can tell you when you have this type of discussion of 30 minutes with your patients, that cuts down the number of people that want to have this operation done on them, and that's what we're seeing in the US right now. And I could have brought you a number of those awards of millions of dollars to patients that have won their awards. It's daily. We've heard 100 million plus lately, but this was one patient I knew personally, and she got 75 million. I mean, this is a daily event in our society in the US. So in summary, these suburethral procedures, they don't restore the anatomy as far as I'm concerned, since it's a vaginal disease. They focus on the urethra when the problem is really in the vaginal support. It's a sling like any other sling you've ever done, with all its limitation of tensioning. It had some technical issues because we don't control the healing really of these synthetic devices. Long term, we don't know. We keep having data and publications showing, you know, late erosions and late exposures. It's very challenging to remove, and it's not the end of the story. Once you remove it, you sometimes are dealing with very complex patients to make happy. Now, SUFU-OX came up with a position statement. I'm a SUFU member, but I'm not much of a supporter of that position statement. Everybody knows that. It's no secret. And part of the reason I have a problem is that they quote 3 million tape being placed in that statement, but there's no registry. Nobody knows where this data come from. I suspect from drug companies, but they should disclose this information if they have it. In the US, this is not something that you have to report. It's totally optional. And if you ever go to the MOD database, which I've done, it will take you upwards of 30 minutes to enter one case. And it's not even easy to retrieve the data afterwards. So unfortunately, the best the FDA can do is picking up that there's a noise, that there are problems, and alerting us, but they can't give you any information on how many of these complications we're about to see in the future. Chris mentioned the Thomas trial. I think for those who are fond of that trial, I agree this is really the top best result you'll have. And I think that if you see already the experts having the problem they had, to me that tells me I don't want to do this operation, because expert or no expert, one day I'll have a patient who's growing pain after TOT, and I can close my practice if I get sued. So I want to thank you for this brief overview. I know it's a bit depressive, but I was the devil's advocate, so I have to play the devils, although I play it with a lot of sincerity because this is my life. I want to thank Chris for introducing many of these concepts to you before I spoke, and to my patients who remind me every day of their miseries. Thank you.
So thank you very much, Professor Zimmern, for that sobering presentation.